Tonight I'm going to be talking about traumatic brain injuries and ADHD and what's the connection. I'll start with the take-home message. There does seem to be a bidirectional relationship. So having ADHD does predispose in most studies to developing or acquiring traumatic brain injury. And one of the consequences of a traumatic brain injury can be a pattern of behavior functioning that resembles ADHD. And why I say resemble is that although some people would say traumatic brain injury can cause ADHD, the official ADHD definition requires that its symptoms aren't caused by any other condition. So some people just call that secondary ADHD, meaning that the person didn't necessarily develop ADHD early in childhood, doesn't necessarily have the genetic predispositions and family history, but shows a pattern of symptomatology that is just like ADHD. So part of the difficulty of research in this area is that we can't do controlled studies where we subject people to brain injuries and see what happens to them. And a second big difficulty in this area is that the terminology, different groups use slightly different definitions of their terms. So we have a category of injuries called traumatic brain injury, which go from mild injury to moderate to severe. And there are some criteria for the progression among those. Clearly, it's a spectrum. Many people equate concussion with mild traumatic brain injury, TBI. And interestingly, many people, when they hear the word concussion or traumatic brain injury, assume that that means the person's lost consciousness. So traumatic brain injury is a diffuse, so as opposed to focal. So focal injuries would be gunshot, other penetrating trauma that affect just a specific part of the brain. Again, TBI is a diffuse affecting overall brain, usually through acceleration or deceleration, the rotational, but the brain's being torqued, twisted at high forces within the skull. So concussion or mild TBI just means that there is a change in brain functioning as a result of this trauma, and the changes, some studies suggest loss of consciousness is present in only about 10% of mild traumatic brain injury. So other changes in brain functioning could be the presence of headaches, the presence of concentration problems, the presence of memory problems, the presence of nausea, blurred vision, vertigo, dizziness, headache, sleep disturbances, mood changes. Any of those symptoms would qualify for mild traumatic brain injury, and those symptoms would be usually persist for days to a few weeks after injury. One of the common definitions is the transition from just the concussive symptoms or mild traumatic symptoms in adult is 2 weeks. So if you're having symptoms longer than that, it's considered post-concussive, even though the word itself means after concussion, but again, the concussion is considered at least the first 2 weeks of adult, at least the first month in a child. So again, most of the research done on traumatic brain injury is done in animals, and it's not clear both for anatomic reasons in terms of humans are kind of weird in how their head and neck are positioned relative to their body, or bipedal mammals, which other than kangaroos and some great apes occasionally, most other mammals aren't. But also our brains have a degree of level of functioning that's more complex than any of our animal models. So translating from the animal models is difficult and incomplete. Where was I going with this? So some of the things so with mild traumatic brain injury, the thought is that most of the damage is coming from shearing forces and stretching forces. Again, some of the neurons, the axonal projections are the largest cells in our body, and stretching, torquing them over powerful forces is likely to result in at least functional disruption, if not physical damage. So the shearing forces disrupt cellular membrane activity and at a slightly larger scale affect the functioning of the brain-blood barrier, so affect blood flow and what gets into the blood within the brain. But at the cellular level, the effect of disrupting cell membranes causes potassium to pour out of the neurons. That pouring out of potassium causes a release of excitatory neurotransmitters, primarily glutamate and aspartate. And that increase in excitatory neurotransmitters, which are ubiquitous in the brain, causes an increase in brain cellular neuron firing and activation at the very same time that there are, again, disruptions in blood flow, probably disruptions in glucose metabolism. So the cells essentially go into shock. They're trying to do things, but aren't getting the energy sources, again, both because of increased demand, decreased supply. And there's a big debate as to whether with traumatic brain injury, particularly at the mild end, whether this is only a functional or whether this is a structural damage is going on. So functional implies we may be affecting ion shifts, we may be affecting neurochemicals released, but the integrity structurally of the cells is intact. Others would argue even if it's at a micro level, if you're disrupting cell membranes, certainly once you're killing cells, you're causing some structural differences. So I think some of the structural function distinction depends on what the scale, both of time and space that you're looking at. I mean, clearly people who've had one concussion are more at risk of having a second concussion in the week following it, which does suggest that there is some ongoing structural propensity for further damage. ADHD, in most, but not absolutely every study, predisposes people to a variety of traumatic accidents. We know motor vehicle accidents are 2 or 3 times more likely if you're in ADHD. A host of other physical accidents into the ER are higher if you have ADHD. And both the impulsive elements of ADHD and the inattentive elements of ADHD seem to be involved. So impulsivity is that one's paying attention before you jump into a situation, or you are choosing activities that are inherently more dangerous, that put you at risk. The inattentiveness is that you're less aware of what's going on in your environment and more likely to collide with things that may cause damage to you. So one additional question is whether than just the increased risk of, and the studies suggest it's anywhere kids with ADHD or adults with ADHD have somewhere 2 or 3 times the likelihood of developing a traumatic brain injury. So one question, though, is it just the incidence for trauma or likelihood that something is colliding with your brain, or are the brains of kids and adults with ADHD more vulnerable to an injury when their brain does collide with something? And I keep saying brain, but certainly body collisions that result in, again, abrupt acceleration, deceleration of the brain inside your skull. So you can slam your body and be knocked unconscious without having a direct hit to your head. But again, at the level of forces on your head, it is a hit to your head, even though nothing directly contacted your head. Is the propensity of traumatic brain symptoms, injuries in people with ADHD just related to the trauma, or is there something more vulnerable in the structure of their brain that makes it more likely to be hurt if they are hit? Part of this, again, is great difficulty in assessing after an incident. So we know the likelihood of being injured has some correlation with the force of the impact, has some correlation, probably the age of the kid has some impact with a couple other factors, but it's hard to retrospectively evaluate, is this injury happening because someone was hit harder or because they were more vulnerable to begin with? So one measure of just looking at how quickly the immediate concussive symptoms persist or how quickly they stop, several studies have suggested that kids with ADHD on average do not persist in their concussive symptoms. So again, this isn't technically post-concussive, but their concussive symptoms last about as long as individuals without ADHD, which would suggest that their brains are not particularly vulnerable, again, that this primarily behavioral reasons that people with ADHD are leading to TBI. So looking at the other direction, again, TBI, traumatic brain injury, can lead to ADHD symptomatology, and particularly problems with impulse control, and attention issues have been noted to be frequent sequelae of traumatic brain injury. So again, what's the likelihood of persistent brain functioning issues after traumatic brain injury? One is the severity of the trauma itself, but that is not by any means a perfect or a hugely, so there's people who seem to have horrendous forces applied who go literally unscathed or largely unscathed, and people with milder, what seem to be milder, can certainly have more persistent sequelae from a traumatic brain injury. So the magnitude of the force itself is one factor, but it's only one factor. A much stronger predictor seems to be the amount of brain dysfunction in the immediate aftermath. So the degree to which amnesia, particularly if you have more than a day's worth of amnesia, particularly loss of consciousness. So if your loss of consciousness more than 30 minutes is strongly predictor of more long-term problems. Again, not an absolute predictor. You can be out that long and not have long-term sequelae. And interestingly, some social factors, at least in some studies, but not in others. So the better educated your mother is and the less household stress dysfunction there is, and a few studies have been correlated with better long-term outcomes. There's lots of speculation as to why that may be, but it suggests that there are factors outside of the impact of the trauma itself. There's also studies looking at genetic factors. And again, we know there are genetic predispositions to ADHD, fairly strong ones, but in kids with no previous history of traumatic brain injury or no previous history of ADHD who suffer brain trauma, there do not seem to be strong genetic factors that we found yet specifying which subset of kids will have long-term ADHD-like symptoms. So the likelihood of ADHD symptoms, again, varies widely from study to study, partly because of where on the spectrum they're looking. Again, if you have more severe brain trauma, the severe end of the spectrum, the rates are as high as a quarter to a half of kids or adults may wind up with an ADHD-like picture. And with milder brain traumatic events, certainly a lower incidence of causing it. One of the interesting things is just like Ritalin or other stimulant exposure has been found to lower the risk of any trauma, specifically brain trauma has been looked at. So kids with ADHD who are taking Ritalin, and particularly those taking the highest dosages or the longer duration of action, have decreased risks of TBI compared to kids with ADHD who aren't taking medication. So again, medications are villainized in many fronts, but they do seem to have some protective effect. So I haven't talked much about chronic traumatic encephalopathy. Recently, there's been lots of concern about heart trauma from football, which certainly a tragic incident, although there's the Buffalo Bills player does seem to be recovering from it. But clearly, brain trauma from getting slammed around, either directly hitting on your head or, again, even body slams have traumatic effects on the brain. We know that there is a correlation, but it's not a perfect one, between more severe traumatic brain events and more frequent brain events, leading to chronic traumatic encephalopathies. That's a diagnosis that so far can only be made when the person's dead and we do brain biopsies. And on brain biopsies, we find tau proteins, fibrillary proteins, aggregating inside cellular nerve cell bodies, as we do see in Alzheimer's, as we do see in some other dementing illnesses. Clearly, it looks like inflammatory properties are part of the process where traumatic brain injury gets converted into CTE, but we don't know what all the other factors are and what may be protective factors. Many people, again, based on animal models, have proposed hyperbaric oxygen chambers or other certain neurochemical interventions, and so far interventions that seem consistently helpful in animal models at preventing longer-term damage have not overall shown great power in reducing the likelihood of brain damage in people. That doesn't mean there might not be substances or approaches that work, but that it's a tricky area to study. That's about all I'm going to say today on this topic. Next week's topic is Concerta, what makes it special, and problems with the Concerta shortage, which are a different origin than the Adderall shortage. And I do see some questions, so I'm going to try to answer them now. So the question was whether a direct hit to the head, the prefrontal cortex, for about 4 to 6 seconds, can that hit cause ADD? So the answer, I'd say, is presumably, and there was a short blackout. So again, blackout, loss of consciousness, although has a loose correlation with severity of a traumatic brain injury is a diffuse, widespread, again, due to acceleration forces. So there's two different big questions embedded in this. One is whether the frontal cortex is particularly if you hit it there, are you more likely to cause damage to it? And again, with focal injuries, and Phineas Gage, who had a railroad tamping spike blasted through his eye socket and through his frontal lobes and developed what in many ways looks like ADD symptomatology in terms of impulsivity, loss of attention, changes in behavior, changes of impulsivity. Clearly, frontal focal damage can cause an ADD picture, but again, with traumatic brain injury, we're talking about a much more widespread, diffuse process. But again, that diffuse process can lead to an ADD picture. And again, although severity, a single severe incident is more likely than a single mild incident, there's not a perfect correlation or predictor there. And clearly, people with multiple, no loss of consciousness brain traumas do wind up with ADD-like pictures. So I hope I answered that. Why do some places have different dose limits for methylphenidate? It says, for example, Saudi Arabia, maximum dose of Concerta is 72, while the maximum dose of Ritalin is 100 milligrams. So what I would say is we're talking about the difference between political recommendations and scientifically objective ones. So why would we have different recommendations in different countries, which we do? So, for example, in many countries, amphetamine-based products are not available or barely available, while Ritalin methylphenidate is. It's not that Ritalin or Adderall is going to work differently in a Chinese brain or a Saudi Arabian brain or a American brain. It's that the governing bodies have decided different standards for what the population risks are and what the individual potential for benefit is. And there is values embedded in that other than sort of the objective data. Yeah, so even in the US, there are different recommendations for Vyvanse versus amphetamine. And again, with Vyvanse and amphetamine, the milligrams of Vyvanse include the weight of the lysine amino acid. So only about a third of Vyvanse is active dextroamphetamine. But the limits there don't correlate to what's allowed or suggested for amphetamine overall, or dextroamphetamine. Vyvanse maximum dose in the US is 70 milligrams, but in 70 milligrams, 70 milligrams only contains about 20 milligrams, 20, 21, depending on your parsing, 20 milligrams of dextroamphetamine, and yet we allow more than 20 milligrams of dextroamphetamine. And theoretically, on multiple levels, the slow-release formulation should be a safer way to deliver a bigger dose. So again, don't look for rationality in terms of drug laws. I mean, the best example of that by far, and this may provoke argument, is that what's the most deadly drug in America and almost every country that I know of? Alcohol, which requires no prescription, no limits, no rigorous limits anyway, and yet we blithely allow that well, there is an age restriction, which is fairly easily skirted because, again, the adults who are using it don't need any prescription themselves. Again, a lot of social, political, and other factors are going on when we're discussing what drug regulatory bodies are allowing in different countries. So I think I've beaten that horse to death. So again, next week's topic is Concerta. Stay healthy, stay happy.